So thank you everyone for being here today for the first talk in our new lecture series. I'm Shilpa Tawfiq and I'm co-chair of the Diversity, Equity and Inclusion Steering Committee for Mount Sinai's Department of Psychiatry. There's been a long-standing history of systematized racism and oppression in our fields, of which the American Psychiatric Association and the American Psychological Association have issued apologies. That's given us full permission as well as the responsibility to openly discuss all forms of racism, bias, and discrimination with our patients, trainees, faculty, colleagues, and our leaders.
And I am Dr. Dolores Malaspina. I am co-chair of the committee with Shilpa and vice chair for Diversity, Equity, and Inclusion in Mount Sinai's Department of Psychiatry. Our committee is rooted in the knowledge that racism, the structure of society, and the social determinants of health importantly influence mental health and well-being. This lecture series is really our first step to broaden the conversation that we are having beyond our own walls, to include the voices of experts from diverse backgrounds and varied experiences. And I'm delighted to introduce our series, Dr. Vivian Pender, President of the American Psychiatric Association and Clinical Professor of Psychiatry at Weill Cornell Medical College, has joined us today to say a few words. She has been an incredibly generative and passionate American Psychiatric Association president in this specific area, and we are honored that she can be with us today.
Thank you so much for inviting me, Dolores. It's really a great privilege and honor to be with you today to give remarks at the inaugural Mount Sinai DEI series. The APA has formally acknowledged the presence of structural racism within psychiatry and the organization, and we are working hard to address these inequities. We're monitoring diversity in all APA entities and instituted anti-racist training, especially for APA leadership. We are making gains, but it's not enough. We still have much work that includes understanding and addressing the impact of the trauma and injury felt by many of our doctors and our patients. In this same vein, we are actively highlighting lived experience and the many contributions. To address DEI, I appointed an APA Presidential Task Force on Social Determinants of Mental Health, where Dr. Dolores Malaspina is chairing a group on research and education and doing fantastic work. In conclusion, I applaud Mount Sinai's efforts to help the invisible, long neglected population of refugees and the racism they face. I have followed Dr. Smith's work, and I'm very much looking forward to his presentation today. Again, many thanks.
Thank you, Vivian. I'm Dr. Ala Popovnik, a clinical psychologist at the Student Trainee Mental Health Clinic, and we are thrilled to introduce Dr. Hawthorne Smith as our inaugural speaker. Dr. Smith is a licensed psychologist and the director of the Bellevue Program for Survivors of Torture. He is also president of the National Consortium of Torture Treatment Programs and an associate clinical professor at the NYU School of Medicine in the Department of Psychiatry. Dr. Smith received his doctorate in counseling psychology with distinction from Teachers College, Columbia University. Dr. Smith had previously earned a master's in international affairs from the Columbia University School of International and Public Affairs.
Thanks, Ala. My name is Alicia Hurtado. I'm an attending psychiatrist here at Sinai. Among his clinical duties, Dr. Smith has facilitated a support group for French-speaking African survivors for 25 years. He speaks extensively at professional conferences and seminars on providing clinical services for survivors of socio-political violence and enhancing cross-cultural clinical skills among therapeutic service providers. Dr. Smith has been recognized for his work with such awards such as the Robin Hood Foundation's Hero Award, the Union Square Award for Community Advocacy from the Fund of the City of New York, and a Humanitarian Award from the Consul General of the Republic of Haiti. Dr. Smith also provides forensic evaluation, human rights consultations, and mitigation services on capital cases for private legal firms and public entities such as the U.S. Department of Defense and the U.S. Office for the Federal Defender. He's also a professional musician, a saxophonist, and vocalist with national and international experience. So we're going to get started soon. Just as a housekeeping note for the attendees, if you have any questions, please put them in the chat for our moderators. Ala and myself, Alicia Hurtado, we're going to be the moderators. If you want to send your questions directly to us, please also just send them directly to us privately. And we will then ask the questions. Also, if you prefer to ask your question yourself, please just raise your hand by clicking at the bottom. There's a tab that says reactions, and you should be able to see a raise the hand. So just raise your hand, and then we will call on you. So we're going to leave an opportunity for individuals to ask questions towards the end. And now I will turn it to Dr. Smith. The floor is all yours.
Thank you so very much. I'm so excited. This is a wonderful occasion, and what an honor to be invited to speak at the inaugural DEI initiative. And I wanted to thank Drs. Alicia Hurtado and Ala Prohovnik-Rafiq in particular for inviting me. And we had spoken, and I mentioned that I had done a presentation at Mount Sinai West back in 2020. I don't know if folks remember all the way back to 2020. Seems like a long time ago. I barely measure things in years and months anymore. I think that was 3 variants ago and maybe 4 surges. But we thought about this, and this occasion was so important, and it seems to dovetail so nicely with the work that we are doing at the Bellevue Program for Survivors of Torture. And the fact that over the last 18 months, 2 years, things have not gotten better in terms of people who are fleeing political persecution, coming to our borders, et cetera. If anything, due to the pandemic and other reasons, things have intensified. So we really felt that it would be good to dive into this material again, and particularly with such a wide audience that has gathered here. Folks know the name of Mount Sinai and how important this is, this initiative. So I'm going to do the New York thing. And I'm going to speak fairly quickly because there's so much that we want to cover. And I really do want to get to the point where we can have more of a multi-log and a conversation. So by way of introduction, let me just say that, okay, your screen should move. Why? There we go. Sorry. So the Bellevue Program for Survivors of Torture, we were founded in 1995. And thus far, we've treated more, as you can see, more than 6,000 clients and their families, over 110 countries, and we really take a holistic, resilience-based approach to working with our clients. We endeavor to rebuild the bodies, minds, and spirits. And as you can see from these 2 pictures, I really like these because you see the modern, and we really do focus on evidence-based practice. But at the same time, Bellevue is ancient. We're the longest standing public hospital in the United States. And there's a lot that we gather as well from practice-based evidence. We learn so much from our clients. And again, we really want to prioritize not just their experiences, but their voices in the healing process. And as you will see in a few minutes, we, as hard as we're working and seeing more than 6,000 survivors over the course of these past 26 years, we're doing a lot, but we're really just scratching the surface. So one of the other reasons I'm so excited to speak with you today is because in some senses, this is really a call to action. It's kind of a call to service. And, you know, and part of it is these numbers, these statistics. I'm not going to go into much detail here because first of all, these are older statistics. These come from 2018. And as we mentioned before, there has been an increase. I don't have the exact numbers, but when we look at people who have been displaced and uprooted because of political, financial, or public health stressors, as well as people who are now climate refugees and all of that, the movement of people across borders from one portion of the world to other are just really, really increasing. But the one number for those of you in this area, people at Mount Sinai and elsewhere in New York City, it is estimated that anywhere between 1.2 to 1.3 torture survivors are living in the United States at this point. And it is estimated that up to around 25% of them may be living in the New York metropolitan area. So we're looking at anywhere between 250,000 to 300,000 survivors in our geographic area. And again, back at that other slide, we were looking at us providing services for 6,000 people over the last 25, 26 years. So again, we are barely scratching the surface. This is a problem that is intensifying, and it is definitely something that, again, I'm just very, very, very happy to have your attention and hopefully to shine sort of a spotlight on this. So who are these people? Oftentimes, one of the very first questions I get when making a presentation like this is, who are these torture survivors? And it really does sound like some sort of exotic other group. But what I can say is, well, actually, let me just start by running through some questions. I wish we were sort of in the same room so I could get your responses, but just some things to think about. Have you ever voted in an election? Do you identify as a woman? Do you belong to part of an identifiable religious group, or perhaps you don't belong to a religious group? All of us belong to identifiable racial and ethnic groups. Perhaps I always feel like my generation, I talk about, have you ever written a letter to the editor? Or perhaps you've commented on someone's blog post or whatever it might be. Maybe you are, or you are close to someone who has a sexual orientation other than heterosexual. So I start off and people are like, who is this guy and why is he asking all these intrusive and borderline inappropriate questions? And the response is that if you nodded your head to any of these questions and many others, I can honestly say that the people we are working with are people just like you. This is not a question of an exotic other. This is about us. This is about a sense of shared humanity. And I think when we keep that in mind, that is something to really focus on. We're looking at diversity and all of that, but we're also looking at shared aspects of humanity and shared aspects of traumatic experiences, unfortunately. So that's who we're dealing with. The why of torture, the why of human rights abuses. And this is something that I learn often from our clients themselves who've talked about human rights abuses being perpetrated on individuals, particularly people who might have some social standing or some power or impact within an oppressed population. And the feeling that if they are able to break the will of that individual, or perhaps to make an example of them through their deprivation, through their suffering, it will serve to break the will of a community so that that community can be further oppressed. And I don't know, many of you go back far enough to have watched the movie Apocalypse Now, but there's a very moving scene in there where someone talks about the horrific human rights abuses they saw, but then the aspect was the horror, the way of utilizing horror, utilizing terror to really quell a population. And one of the things about this, and when we talk about healing processes going forth, is that the healing process in and of itself can also be seen as a subversive sort of action, that there was a pronounced will to break an individual, to break a community. The fact that we are not just dealing with victims. When we talk about the Bellevue program for survivors of torture, when we named the program many years ago, we chose specifically the word survivor as opposed to victim, because we really felt that any of us can be a victim. Wrong place, wrong time, wrong circumstances. But to be a survivor is about a comportment. It's about an attitude, a way of responding to life. And we are working very much with survivors who, despite the purposeful and violent ways that people are trying to extinguish their humanity, refuse to relinquish that humanity, and their healing can be seen as subversive. So the scars of torture, and they're multifaceted. Sometimes the MDs with whom I work, they will show various slides. We used to refer to it in our sort of gallows humor as the gory slideshow, but we're not going to do that this morning. but understanding that we are working with clients who have suffered amputations, who have been burned, who literally carry the physical scars and wounds. But as a mental health service provider, and those of us who are in that field in various different domains, oftentimes what we see is that the emotional scars of torture, sorry, I don't know how that mute happened, but here I am again. The emotional aspects can be just as pernicious, if not more so. And one of the things, and I don't like to use the word sophisticated, but we're beginning to see now the perpetrators of human rights abuses and torture have become more sophisticated in hurting people without necessarily leaving the physical scars that one might see that could be reported by Amnesty International or other NGOs. For example, I worked with someone who had been horribly physically abused during their incarceration, but one of the things that we worked on was this person had been through a mock execution and talking about what it was like to be dragged from their cell, to be tied up, to have their eyes banded, to be told that they are about ready to be killed, to be taken up there, to be told, say your last prayers, you know, whatever it is you need to say, do it now. This is the last breath you will take. And then feeling the cold muzzle, and the person gets into such detail of what it felt like to feel the cold steel of the muzzle against their temple, and then the click as the person fired a blank and the person, the survivor, passed out. And years later, all the physical scars have healed or what have you, but what wakes him up 4 or 5 times a week, nightmare sweating, is that click that he heard when he thought his life was ending. So again, we need to think about a sort of a more sort of complex way of understanding what people have been going through, that the physical and emotional impact serve to reinforce one another. Okay, I don't know why my slideshow is, there we are. So some of the challenges experienced by the survivors. We're looking at multiple losses. Oftentimes I'm doing a presentation like this, I will ask people to write down 3 or 5 of the most important things in your life, those things that make life worth living. I will gather up, you know, anonymously, I will gather up all of the papers at the end and begin to read from them. And we hear things like familial relations, being a spouse, one's career, one's ability to worship, one's health, all different things. And it's sort of a bit of theatric, you know, overblown theatrics. I will take these pieces of paper and rip them to shreds and ask you to consider your life. If those things that you found most valuable, that made life worth living, had been violently and purposely taken away from you, and that you were currently unable to recapture them. Now, overblown theatrics aside, that is part of the context in which we are dealing with our clients. And there are ongoing effects. I mean, this list can be really long in terms of the different things people have gone through, whether it's a civil war, a rebel insurgency, homophobic persecution, gender-based violence, some sort of social dislocation. Oftentimes living in their country, internally displaced, moving from place to place and hiding. There's a flight and relocation to a neighboring country. And very unscientific, but I find that oftentimes when you go to a country that is war-torn, chaotic, and impoverished, you go across the border and you are often landing in a country that is chaotic, war-torn, impoverished. And now these folks who have crossed the border have that sort of xenophobic response of, oh, here are these refugees that are coming in. Those of us who have had the opportunity to either visit or spend time in refugee camps, we know about the endemic public health risks and the emotional risks. But we're not seeing most of the folks there, we're seeing them here. This aspect of refugee trauma, and I hope that this is something we can talk about more. You know, we are not just talking about a bad day that someone went through back in the Democratic Republic of Congo. We are looking at people who are going through incredible lengths to escape from their home country. Perhaps you've been following the news of many people from West and Central Africa who have been dying in their pirogues as they try to cross the Mediterranean into Europe. Many of the people we are treating now here in New York City, particularly with the pandemic and flights weren't coming, but have been coming through several South American countries, making their way north towards the border. And there is one particular zone in between Colombia and Panama where people are coming north. It's called the Darien Gap. And it's about 70 miles of untamed, perhaps one of the most brutal forests in the world. And many of the French speakers I work with, they call it the Forêt de la Mort, the forest of death, where people making their way through this and they're seeing cadavers, they're being attacked by militias, there's snakes, scorpions, all this different thing. This also adds to the trauma. Then there's the immigration processing, and this is definitely something we need to talk about later on. The fact that our asylum system was already overburdened, was already moving glacially slowly, but now with the pandemic and some of the changes that were put forth, particularly during the last administration, things have frozen to an almost stop. And so we are dealing in many cities, but I'll speak from the case of New York, with sort of an unseen family separation crisis. We're seeing much of what happens at the border, and we have those vivid images. But what we don't see oftentimes are people here in our city who have been separated from their families for 5 years, 6 years. We're still in the process and waiting for their first asylum interview. And we're not getting the film of someone being called at 3 a.m. when their spouse or their children is saying, do you still care about us? Have you found another family? What's going on? And oftentimes these are some of the people we see in the community who have been dubbed essential, particularly during the pandemic, people who are driving our Ubers and Lyfts, stocking our shelves, working as home health aides, et cetera. So the resettlement in USA is really, really difficult. Now, people will respond to these stressors in different ways. Okay, and we're going to talk about that, but I think that one of the things we need to keep in mind are around diagnoses. So PTSD is a diagnosis that gets used often within this population. And those of you who are attending this, know about PTSD, and I just have that up there, but I want to sort of throw a couple of caveats out there as well. Thinking about what we just talked about in the last slide, and all those different recurrent reinforcing stressors that keep the trauma alive in the present. Can we really talk about post? Does the P in PTSD make sense when the stressors are still going on, when you're still separated from your family, when you still don't know if you'll be deported and sent back home? There's nothing on this slide that deals with survivor guilt and the fact that I made it out, but other people who were within my democratization movement didn't. I feel guilty because I'm here and my family's back home in whatever country that might be. I think that it is important to hold on to these diagnoses. We don't want to throw these out, but there's an incredible psychiatrist who works here, Dr. Ashra Raja, who often says, we do not treat diagnoses. We treat people who have a constellation of stressors and resources and who exist in a context. And I think that that's very important for us to hold on to. We're not trying to get rid of all of our clinical or diagnostic tools that we have within the DSM, but I think that there needs to be a sense of broadening it to even understand what's going on, to be able to see what is happening with the particular person who is presenting in front of you. So rather than looking at some of the diagnostic criteria, one way that we really sort of look at this is a constellation of stressors. If I were better with my PowerPoint, there could be a lot more lobes to this particular flower, and how someone might be impacted cognitively or behaviorally, spiritually, etc. But what I want you to really sort of take from this slide is that where we live as human beings, where our survivors live, is in the middle of this flower, where everything has an impact on the other sort of things. So, the physical trauma, and we're looking at things like paresthesia. Our Tibetan clients who come do not have a word for depression or stress in their language, but they might present with belly aches or headaches that maybe have no visible etiology medically, but it's because there is this overlap between what's happening physically and what's going on emotionally. People who have switched, I've worked with Muslim clients who perhaps are not sleeping well and maybe will drink a beer or two to self-medicate. And maybe for the average New Yorker, drinking a beer or two doesn't seem like a big thing, but for somebody for whom that is haram, that is specifically forbidden, but that's what you need to do to take care of yourself. What are all these different things flow? And one of the things I want you to hold on to is that the bad news is that there's so many different ways that our clients are impacted. And the good news, and what we're going to get to soon, is that there are so many different ways to have an impact and to intervene that are tangible and effective. So that's sort of at the individual level. I'm going to, again, I'm going quickly and I apologize for that, but I want to get to some of the insights of clients that interpersonally, or perhaps even how someone will present to us or in session with us or when they come to our clinic. And we're looking at their ability to take in and process information. How do they relate to other people? Do they even have the ability to think about the future, or is it just totally a pessimistic outlook? What are their feelings about him or herself? What do they think about the world? Trauma does more than just impact your body and your ability sort of in-house, but it affects the way that you engage with other people. And for our survivors who are coming in, and again, at our program here at Bellevue, we work predominantly about 95% of our clients are either in the asylum process or will be in the asylum process. But there's so many different ways that they are marginalized. In terms of educational functioning, we have a 17-year-old girl who just spent the last 3 years in a refugee camp, who was not able to go to school, but now she wants to engage in school. How do we place her? Do we put her with the class that would be age and developmentally appropriate with other 17-year-olds, where she might drown in terms of what she's able to do academically? Or do we place her with the 14-year-olds, this is where she left off, but where she's totally not, on the same developmental level? Social services, people, proud folks who come in. We've had clients who have walked from the Bronx to Bellevue here on the Lower East Side because they did not want to ask for a Metro card. They were always the folks who took care of their family. To ask for something is really harmful, it's really hurtful. Again, we're in the asylum process, so legal advocacy, vocational, professional. Let me just say, one of my clients told me, you never know who's driving your taxi. You never know who's sweeping your floor or sitting with an ill relative at a nursing home. Many times the people who come to our program are people who were targeted because of their leadership abilities, because of their position in their homeland. So one never knows. So there are just so many ways that people are devalued. So one of the first things we need to do is assess and see where people are. And something, I was in Pittsburgh about within 2 or 3 weeks after that horrific attack on the synagogue back in 2018. And we were at a hospital in the Allegheny health system. And one of the attending physicians spoke, and I really thought this was wonderful, when he was talking to his residents about the review of systems that are done in medical evaluations. But he wanted to expand that beyond just a review of systems. But in order to do that, we need to review the context in which someone is living. We need to be open and review the experience or their feelings as well, because just getting a sense of what hurts and where on the body, whatever, will not give that totality where one can really target what we do. The interdisciplinary focus, as you remember from the slide a few slides back with the flower, and that these things overlap. We do not want to sort of be siloed off where psychiatric treatment is over there, the social services are that way, physical is that way. No, we need to come together. And as a program, and we can talk about this more later, the way we try to bring folks together in terms of our intake processes, in terms of our case updates, our case dispositions, where every discipline has a voice and has impact, because every decision we want to make for our clients needs to come from this interdisciplinary place. Our founder, the founder of our program, Dr. Alan Keller, one of the things, he's a primary care physician, and he said if he only had one question to ask a client in terms of the assessment, he would ask how you were sleeping. Because so many times with issues of trauma, insomnia, trauma-related nightmares, interrupted sleep, all these different things, this can often serve as a window to get into some of these deeper issues. And what we also want to do is normalize the conversation. So again, it's not that the psychiatric stuff, okay, that's for folks over there. We don't want to stigmatize. Oftentimes what we're able to talk to people about is like, you're not sick, but you are dealing with sick circumstances. You are not abnormal, but you are dealing with an abnormal situation. So we avoid stigmatizing them and remembering, as we get trained every year, as we get re-credentialed, what is the best denominator or determinant of someone's level of pain? It's what they tell you. It's not what we expect. They are the experts in what they're going through. So these are just some of the things, the ways that we can be humble and use that humility and allow the client to begin to really engage us and take us through, so that we can begin now to get out of the context and move towards the interdisciplinary approach to healing. And again, with this particular slide, we live in the middle. Not everyone comes to this program and immediately want to come speak to a psychologist. That might not be what they have in mind. Oftentimes, the longest line we have in our program is outside our legal services office. And people are saying, hey, how do I apply for asylum? How do I get my family here? How do I save them? And they might not have much of an interest in coming to speak to a psychologist, but it might be our legal services liaison who speaks to them and says, well, you know, you seem like you're really isolated around some of this. And you see, you know, but, you know, Dr. Smith runs a group for French-speaking Africans, and he might be someone that blah, blah, blah. They talk that way. And now that the client has been engaged with someone, perhaps they've gotten some medical treatment that helps to reduce their pain levels or what have you, there's some value to this program, that our internal referrals seem to stick and work very well. When we're able to have some sort of community connection, so the person understands it's not just me. There are others in this situation. We're trying to navigate these troubled waters, ways of engaging them spiritually. And again, when you help to reduce someone's physical pain, that can also help to relieve some of their emotional pain or their worries. Again, what I said before, the bad news is that our clients are challenged in so many different ways. The good news is that there's so many different ways to intervene that can be effective. So some of the things we want to look at in terms of our trauma-informed approach, first is around safety. There's the physical safety. You know, we try to do things with our offices, and you see behind us to have artwork, to have plants, to do this, anything to sort of, because I know if you go to Wikipedia and you look up like ridiculously chaotic urban hospital environment, I think there's like a 4D like image of Bellevue that comes shooting out at you. We've had clients who have turned and gone home because they've seen police officers or prison security or what have you, with uniforms, with billy clubs, and many times human rights abuses are perpetrated in civic institutions, whether they're hospitals, whether they're police barracks, what have you. So anything that we can do to help the client to feel safe and welcomed, even if that means meeting them at the door and literally helping them to navigate the hospital. A few months ago, I was called into a session, a suicidal consult by a trainee, and there was a woman in there. And when I walked into the room, and I'm a fairly large person, when I walked into the room, she breathed a sigh of relief. And that's not always the response I get when I walk in a room. But she remembered when she had first come to our program and was waiting in the hallway, and I offered her a glass of water. So sometimes anything that we can do to sort of alleviate, reducing the ambiguity so that people can know what to expect from us and how to move forward. Anticipatory guidance is a fancy way of letting them know what's coming forward. But within safety, one thing that is really embedded there is the notion of trust. And a quick anecdote I want to share is I worked with a woman from Cameroon. This is a good 20 years ago. And she had been part of an elite family. She actually had bodyguards from the time she was a little girl till she was an adult. And when there was an upheaval in her country and an attempted coup, the people who turned on her were her bodyguards. So when we're talking about trust, she said, you know, there's absolutely nothing you can do to earn my trust. Because even if you say all the right things, even if you do all the right things over the course of 20 years, that's what my bodyguards did. And ultimately they betrayed me. So there's nothing you can do to earn my trust. And I responded with silence. I had nothing. But she continued and she said, you know, there is nothing you can do to earn my trust, but perhaps it's something I can offer because I really need help. And it really changed the way I began to view things, because I realized that there are things we can do to destroy the trust between us and our clients. But honestly, we can't really earn that trust. We have to look at it as something that is a precious gift that is being bestowed upon us. And then we do everything we can to really sort of undergird that. Another aspect I just wanted to put out here is empowerment, and that with these human rights abuses, torture, etc., people are being purposely and violently disempowered. Anything that we can do to help raise someone in the hierarchy, again, so it's not this all-powerful helping person and this helpless victim. It's about a survivor. It's about people who will learn from one another. And one sort of soundbite I hope you'll take from this is that it doesn't have to be therapy to be therapeutic. Again, oftentimes the legal services that are being provided here, medical services, even just connecting folks to information. We've done a lot of work over these last 18 months about getting information out to people around COVID, around vaccines, around how to keep oneself safe, et cetera, as people are already traumatized and wondering what it is that they've come into. It doesn't have to be therapy to be therapeutic. Again, it's the humanistic touch. So we learn from our clients. And I apologize for going through so much of this so quickly, but there's so much we want to get to. We do a lot of work in terms of groups, because in many cultures around the world, the thought of individual psychotherapy might be unheard of, or it might be stigmatized. And one of the things I learned when first starting here, when I was working with largely Francophone African clients, was that it would be very rare for them in their home country to go to a psychologist or a psychiatrist or a social worker. What might make more sense would be turning to the extended family, getting that support, asking the elders for advice. And so we took a chance and we said, well, maybe we can try to formulate a group that could serve as an extended family, even if it's not a blood family, but a spiritual family, so to speak. We did this, we started in 1996. And this group, the Francophone African group, is still, we've done 25 plus years. And I've worked with a lot of other groups. It's hard to get a group going for 6 months. It's been 25 years. And part of the reason that it has succeeded is because we allow our clients to lead, to teach us, to really co-construct these interventions so that their voices are heard. You know, sometimes, and what we're doing, and again, trying to empower folks, I might even ask somebody what languages they speak. And someone says, oh, I speak Peul, I speak Malinke, a little Susu, I studied, Quranic Arabic at school, I speak French, I'm learning English. Because many times we're working with people who we might be speaking with them in English, but perhaps it's halting, or perhaps there are heavy accents, and people might see themselves as being lower in the hierarchy because of the way they're expressing themselves. And then I will just let them know that as a proud American, born and bred here, I come from a culture where we barely speak one language well. My in-laws in London say it's definitely not English. I don't know what you New Yorkers are doing, but that's not English. And if we were doing this, if we were having this conversation in my fifth language, it would be a really short conversation, anything, so people can see that they are valued and valuable. And part of the magic, I think, that happens in our groups, whether with French-speaking African survivors, with Tibetan-speaking survivors from Tibet, Nepal, Bhutan, and all that, is that people become part and parcel of the healing experience for others. They begin to recognize themselves and internalize a sense that they are needed, not just needy. And part of this, again, comes really through the way that they're able to engage with one another. So it's not just about expertise from the staff, it's about a familial really joining. And as I think it's a Native American expression, it says, sorrow shared is half, or joy shared is double, and really trying to follow. So how are we doing on time? Okay, I gotta speak even faster. So a few of these things, I just wanted to share some insights from clients. One of my great supervisors, Harry Brewer, used to say that as a psychologist, we do not walk into the room with Freud or Adler or any of those folks. we walk into the room with ourselves as a healing instrument, that the power of the empathic human relationship is really the coin of the realm. This is where the interaction happens. In a group session, we have people talk about, again, the purpose of torture and why they do this, but the entreaty to not give the victory to people who do not deserve it, that your existence, again, this speaks to the sort of subversive nature of healing, that they did everything they could to squelch you, to put out your flame or what have you. And as they say in French, le bien-être est la meilleure vengeance. Being well, living well is the best vengeance. How do we heal one another? How do we move forward? That there's a big difference between character and circumstances. I have had clients come into my office and say, you know, Dr. Smith, I don't recognize myself. I look in the mirror, I never dress the way I'm dressing now. I used to be the head of an extended family. Now I'm sleeping as like the 14th person in a 1-bedroom apartment. We sleep in shifts. I'm standing out in the cold, washing cars in February. Who am I? What have I become? But beginning to do some of that work, we begin to understand that if you were somebody who was intelligent back in your home country, you're still intelligent. If you were, you know, humanistically oriented, if you were someone who was generous in doing those things, the circumstances might have changed, but if we can just hold on to those elements of character, those are the things that will help to guide us as the circumstances continue to change. And we can never make the promise that things will be just like they were before. No one in the world can make that promise. But the fact that as circumstances continue to evolve, holding on to our character helps us to navigate that system, navigate those ups and downs and move forward. So again, holding on is sort of something that really feeds into that notion of the purposeful existence. Rien n'est facile, mais tout est possible. That comes from my French-speaking group, where they want to know, for people who are coming here, that nothing is easy in this country or in the world, but everything is possible. And the last thing I'll touch on this slide, because I know I want to get to the Q&A soon. I talked about some of the immigration imperatives and, you know, how we have this sort of unseen family separation crisis. There was a time in the group, and we've actually had a couple of people who have self-deported in the last 8 to 9 months, who have just, it's been too long. They've been without their children for too long. There's a gentleman who came in the group from Guinea, and he announced to the group that he was going home. Didn't have his asylum, but it had been 4.5 years. He'd been waiting. His family were crying so much, he just could not take it anymore. And he said, look, I know that if they find out that I've come back home, they will find me, they will seek me. I will at least be tortured again, if not killed. But maybe I'll get a week, maybe I'll get 2 weeks. And that'll be enough, because I have to go home and hug my babies. I cannot tolerate the fact that I can no longer hug my babies. They need me. Well, he was supported by the group, and people shared their experiences. And there was a gentleman from Congo who had just recently won his asylum, and he was telling the heart-wrenching story of his family separation and all the things he went through. And the advice he gave this young man was, you can no longer think about your family as the family you left behind. If anything, you have to think about your family as the family that's in front of you, and that you are working through all these complicated challenges to get to them. If you think about them being behind you, you will drown. But if you think about them in front of you, hopefully you will be motivated and keep pushing forward. And it was just such a beautiful kind of reframe. It was successful for him, and it helped this young man to hold on. And he is still here with us. 3 years have passed since we had this conversation, and he is still waiting for his first asylum interview. So again, our sort of arc of treatment has changed over the years, that now there's this sort of plateau or a trench, I would almost say, that we're helping people to tolerate what is intolerable, explaining what is inexplicable. But so much of what we're able to do now is really based on the insight and wisdom that we get from our clients. 2 more slides and I'll turn it over to Q&A. This one I just want to speak on briefly, that again, this is a call to service. It's a call to action. We really hope that more of us, you in the community, will be involved with this. But please understand it's difficult work. We are faced and we're hearing some of the most horrific things that human beings do to one another. But at the same time, we're always balancing that with the fact that we have this face-to-face contact with these incredible manifestations of human resilience. And how do we take care of ourselves, sharing with like-minded people like this, measuring our victories in really small steps, making sure that we are kind of a conduit as opposed to a container, and finding some ways to sublimate what it is we're hearing and try to transform it into something that is beautiful. A lot of my external sort of healing that has to do with music and taking these things together and transforming it into something. But again, there's a whole longer conversation we can and should have about this. I know that you will have, but I just at least wanted to touch upon that. And we get to my last slide. And again, we learn so much from our clients. And this is from a group session I had. Again, it's a long time, it's about 20 years. And there was an escaped slave from Mauritania who was really having a rough time and wondering, what he could do for his family. And he asked the question, what are the qualities that we need to change the world? Or at least what are the characteristics we need to survive the world? And as a group therapist, I said, well, they're going to talk about this all night. They're never going to come to a consensus. But I was wrong, as I frequently am. And the 9 people sitting in front of me, they came up with 3 things. And they said, you need la sagesse, le courage, and l'espoir. Wisdom, courage, and hope. And they went further. And they said that if you have 2 of these 3 qualities, no matter which 2, it will be insufficient. Because if you're a courageous and hopeful person, but you lack wisdom, chances are you're going to go about your activities in a way that is unsuccessful. And I'm sorry for the telephone, there's no mute button, that will be unsuccessful. And therefore you will fail. Conversely, if you're wise and hopeful, but you lack courage, then you'll be in a situation where you never act on your spiritual proclivities. You will not move forward. You'll be trapped in a prison of inertia. But if you understand this population that we're working with, the wisdom is there. And I'm not talking about advanced studies necessarily. I mean, sort of a moral wisdom, a cultural wisdom, and l'éducation de base, as the French speakers would say. And the courage. Think about what you would have written on that piece of paper, the important things in your life, if they were ripped away from you, all the different steps they've gone through. We don't even have to touch on courage. But what they said is hard to hold on to is hope. And they surprised me again by going further. And they said that hope is not so much something you have. Hope is something you do. It is a comportment, it's a way of, it's an engagement, it's an activity, it's a way of really leaning into what the world challenges us with in an active sense. It is literally an active capacity to hope. And perhaps the most important aspect of that is that the capacity to hope is something that can be shared. And that is kind of how I see what we do in the group. That is how I see what we do as a program and in this community with all our partners. We are in the business of helping to share the capacity to hope with these survivors who can then use the wisdom and courage they already possess. So I think that in the service of time, I should stop there and give the clients the last word. Again, I just want to thank you so very much for including me in this inaugural session of the DEI. And let me stop monologuing, and I look forward to speaking with you folks and hearing what your questions or comments might be. Thank you so very much.
Thank you so much, Dr. Smith. We have a couple of questions on the chat, so I'm going to read this last question here. Are there any texts or academic journals you would recommend for a deeper understanding of the issue, population health outcomes, treatment modalities?
There are a number of really good books. There's the Torture Journal, which is from the IRCT, where they touch on a lot of these different issues. But what I can do, I can also collect some of our recent bibliography. Actually, there's the National Capacity Building program, which the NCB, which is part of the National Consortium for Torture Treatment Programs, and they have a very extensive bibliography and reference list. So the healtorture.org is a place that you can go as a first stop. I will also look at some of the volumes and things that we've been doing here. We published a book, I can't believe it's already 2007. Guess we need to do another one. It's called Like a Refugee Camp on First Avenue. That one is still available electronically, or strangely enough on eBay. I saw that the other day and I was like, what? Anyway, but yes, there are definitely ways we can get that to you. And again, with the NCB, healtorture.org, there are a number of webinars and things that are archived, like this one will be, and there's a good way to start. And if not, if anyone needs to get in touch with me directly, my email would be hawthorne.smith@nyumc.org, and I'm also happy to answer questions there. Thank you.
We have another question about any training opportunities at the Bellevue Program for Survivors of Torture at the moment.
Yes, so historically, there's a long arc where we used to have a good number of psychology externs, and interns would rotate through psychiatric residents, social work students. Around 2017, 2018, due to some financial things, et cetera, our program had to downsize, but we are quickly building up. The hallway here is totally full, and we're getting to the point now where we do expect, we do have psychiatric residents who rotate with us, but in terms of psychology trainees, we hope to get that up and running in the next year or so. And we also do have one social work student who was with us, as well as someone who's been placed with us through the Mental Health Service Corps. But what we're trying to do, and part of my job as director, is getting out there and trying to put the resources in place so we can bring more people on, because the need is increasing and intensifying. So again, this is a call to action, a call to service. So thank you for asking that question. And also, depending where you are in the country, reach out, because through the consortium, where we have 34 different centers around the country, there might be opportunities elsewhere in the country as well.
Another question is, what is the clinical diagnosis that you have found most often gets under or overdiagnosed in refugees?
I think sometimes PTSD, as we were discussing before, some of the caveats I put out there, particularly within the forensic realm and for people who are seeking asylum, we have had lawyers sometimes who have pushed back and said, hey, where's the PTSD diagnosis? I don't see it. Where what we might see is maybe more aligned with depression or more anxiety, or what, doesn't hit all the exact criteria. And the way we approach, we come from a treatment perspective. Usually the sort of gold standard in terms of psychiatric evaluation, psychological evaluation for asylum seekers are the one-time assessment. And again, our colleagues at Health Right International, I hope that they're on this call as well. They do this, and it's sort of a one-time evaluation. We are blessed in the sense that we often have a more longitudinal connection with our clients, or what have you. And sometimes we do that work and a lawyer will say, hey, where's the PTSD diagnosis? And part of what we need to say is, like, that might have been relevant a few months ago, or perhaps that was never. But when we look at someone who has maybe an adjustment disorder with anxiety and depressed mood, or more depressive and this and that, but does not meet full criteria for PTSD, that does not weaken their case. Oftentimes we're able to say this actually argues against the fact that somebody might be malingering or exaggerating their symptoms or whatever for a specified secondary gain. If anything, we see this going in the opposite direction, where someone is engaging in a very real way in their treatment modalities. They're engaged in a very sincere way, and we've seen progress. If anything, that gives credence to what they're going through. So oftentimes we have to have that conversation with legal teams. So I would say that PTSD is a very powerful diagnosis that we have in our toolkit, but it's something we need to really think about for the reasons specified, but also in the sense that it might not always be the diagnosis that is most helpful for somebody in their asylum processes, depending what it is that they present to you.
We have time for one more question. This is coming from Ms. Court. Thank you for a very stimulating presentation. Do you work with Venezuelan citizens who have been tortured and or seek asylum? We are the Venezuelan Association for the Advancement of Behavioral and Cognitive Therapies.
Wow. Short answer is yes. We have now treated clients from more than 110 countries. I think that we're up to 116, and Venezuela is definitely on that list. And as I talk about what's going on and folks coming through the Darien Gap and all of that, trying to come to the border. And we know that many of the people coming through there, it seems like Venezuelans and Haitians, the percentages of them among these sort of groups passing through there has increased. And we know that unfortunately the ongoing turbulence in that country is producing more folks. There are other torture treatment centers around the country. As I mentioned, there's a Libertas Center at Elmhurst Hospital in Queens here in New York. A lot of folks doing good work, but yes, if someone came here from Venezuela or what have you, and is applying for asylum, this would be this would be an appropriate referral, and we would check that person out as well. Yes, absolutely.
So we'll stop now. And I just want to thank all of our attendings for joining us and for participating. And please be sure to look out for our next lecture, which is coming soon in March. And so I'll pass it over to Ala.
Thank you so much, Dr. Smith, from the bottom of our hearts for taking the time to be our inaugural speaker. We really appreciated your enlightening presentation and wise words on this very important topic on approaches to working with this very vulnerable population. Thank you so much.
It's my great pleasure. Thank you, everybody.
Thank you all.